Hello, and welcome to the RSNA Radiographics Podcast. My name is Jenny Weaver, and I'm a musculoskeletal radiologist at the University of Texas, San Antonio. I am here with Jonathan Revels, a chest and body imager in the Department of Radiology at New York University. Our episode today is being recorded at the 2025 RSNA meeting in Chicago.
Our guest for today's podcast is Kate Klein from the University of Michigan, who is a co-author of Patient-Centered Radiology, Implementing the Trauma-Informed Care Framework. Welcome, and thank you so much for being here.
Thank you for having me. I do also want to give a special shout out to my co-authors today. Sydney Torres is a current intern who will be joining us at University of Michigan Radiology residency, and she was a fourth year when she wrote this with us. And Angelica Alexopoulos, who is a current M3. And again, I can't thank them enough for all the hard work, as well as Dr. Janet Bailey and Dr. Colleen Neal at the University of Michigan. So thank you for having me on this really important topic.
So, Kate, why is radiology such an important setting for trauma-informed care?
One of the things that I realized is that people don't understand that radiology is actually one of the most vulnerable points in a patient's entire healthcare experience. Patients are with unfamiliar staff, the encounters move quickly, and many procedures require exposure, immobility, or physical contact, and can be quite intrusive. For someone with a trauma history, even a routine exam can feel threatening or disempowering. So radiology has this real unique opportunity and responsibility to build safety and trust right at the moment. Trauma-informed care is a culture that has been increasing across the medical community, and I think a huge gap is not recognizing how important it is in radiology.
So what tends to trigger anxiety or discomfort during imaging procedures?
A lot of triggers are things we don't even think about. It could be something as simple as undressing for the exam, lying on a cold table, the bright lights, especially loud equipment, or just being touched without clear explanation first. There's invasive steps like compression during mammography or speculum insertion during a hysterosalpingogram can also be incredibly triggering. Even long waits with no communication in that waiting room can heighten anxiety because patients feel powerless or unprepared for what's next.
What parts of patient-centered care are often overlooked, in your opinion?
I think we often miss subtle but very important moments. Asking patients what name or how they'd like to be addressed, whether they want narration during a procedure, if they have any concerns before the procedure. Consent tends to be viewed as a checkbox instead of an ongoing conversation, especially in radiology. We don't always address comfort factors like privacy, temperature, or noise. And these really small things, they can make a huge difference.
What are the most common unintentional misses you see during your practice?
One of them is communicating delays, explaining what will happen as you move along a procedure, and also not sharing any information that you might have with the team around you that's working with a patient in radiology. So patients can end up repeating themselves or having their preference overlooked. So it's really important to have a real team approach, not just with the faculty, but with your staff. Something also, or comments like, your results will be available soon, is just a real classic example of a vague follow-up that leaves patients anxious and confused.
How should trauma prevalence shape our approach, do you think?
So the prevalence is actually very, very high, and people don't always realize that about 70% of our population has experienced some sort of trauma in their lifetime, both male and female. And I think that we should have a mindset to take this as a universal precaution and make the assumption that every single patient has had a trauma history, whether or not they disclose it. And the idea is getting to a point where they don't need to disclose it because they feel safe.
So which domains of trauma show up most clearly in imaging encounters?
I see mental and physical responses most often. Anxiety, hypervigilance, difficulty concentrating, flinching, changes in breathing. But the social and spiritual domains come up too, especially around issues of dignity, identity, and trust. Patients who don't feel respected, it's hard to gain their trust, and we want to stabilize that entity with radiologists and our patients.
So you just mentioned how often we are probably encountering patients who have experienced a trauma. So how can we encourage our teams and help our teams stay sensitive when patients aren't disclosing this trauma to us?
The key is to create an environment and culture where there is an assumption that patients have experienced it. Again, I go back to this mindset of a universal precaution. Even simple things like, please let me know if you want to pause, signals safety and gives the patient autonomy and make them feel a little bit more in control of the exam.
So, how do you think understanding, say, the neurobiology of trauma can help inform care?
Sure, I dare to talk about the amygdala. Something else I do like to talk about is the sympathetic response. I teach with my residents and the medical students that our goal is not to even start the sympathetic response from occurring, because it's if you rang a bell and the bell's going to keep going off and vibrating even after you feel like you have maybe tried to calm down a situation. So if you can prevent that response from even starting, then you are successful in reaching that goal.
So in your paper, you talk about having teams realize. Can you tell us a little bit about that?
Yeah, so Realize is the first of SAMHSA's 4 Rs in trauma-informed care. SAMHSA stands for the Substance Abuse and Mental Health Services Administration, which is a federal agency that guides behavioral health best practices. Realize is about truly appreciating that trauma is common, that radiology procedures can accidentally recreate aspects of past trauma. It means going into every encounter aware that someone might be scared, triggered, or trying to hold it together, even if they seem calm on the surface.
This concept may be really new for a lot of our listeners. So, what do you think providers should be looking for when they're trying to recognize trauma responses?
I think that we, in quotes, say read the room is one idea of looking for emotional cues like fear, withdrawal, the physical signs like shaking, sweating, freezing. They also might shut down completely after being very verbal during the consent procedure and explanation. Sometimes patients also start to dissociate, and that also can be a clue and a cue that they're undergoing some trauma, and we just don't want to re-traumatize them.
Obviously, you want to try and minimize any triggers for someone's trauma. So, when people are implementing these changes or really discussing how to approach them, which triggers do you think are easiest to fix and which might be a bigger change?
I think one of the easiest fixes is language. It's just a mindset change. Instead of taking a lot of time to create a different environment that you think you might need for trauma-informed care, it could be just something as simple as language, lighting, temperature, knocking before entering, which also, in some circumstances, you wouldn't really think about if, for instance, you were walking into a room where a patient was about to have a barium enema. You can still knock on a side door and say, "Is it okay? I'm coming in." It doesn't always mean an office space or a clinic.
So if I wanted to help my patients with some terminology swaps, can you give me some suggestions of some good ones?
Yeah, some really easy ones is referring to a table as a bed. We do not say bed, we say table. Instead of saying sheets, we say drapes. And a big one that we don't realize we say often is, can you turn to the left for me? So just removing the quote for me is also an easy change. Asking to touch the patient before you touch them on the shoulder. I'm in breast imaging. So in breast imaging, I let them know I'm going to be putting this ultrasound probe on your breast. Are you okay? So that's easy terminology switch.
So, how can departments integrate the 6 core principles into daily work that you guys talk about?
I think it's not an easy fix. It's not an easy answer, but just starting by looking and thinking about your own culture and environment and where can you see that re-traumatization can occur in your department. So ways to integrate these 6 core principles could be something as easy as posters and communication in just regular staff meetings. We really also want to hold each other accountable. So by gently reminding our staff and our peers about this as well.
So, Kate, back when I was a resident, you were my attending, and you are an amazing teacher of both breast imaging, body imaging, and also the things that we are talking about today. I remember learning these things from you. Can you talk to us a little bit about what you think the competencies should be?
Yeah, I think it's a great question and ironic that I'm going to say communication is probably the main competency here because one of the myths about radiology is no patient contact. And one of the main reasons I was attracted to radiology was that there was plenty of patient contact, but the patient contact is intense and very important in that time of a patient's experience. So I'm able to give 150% of myself in an empathetic role, in a listening role, a communicative role. And I don't want to sound not sympathetic here, but I also don't have long-term relationships with these patients. So I can give them 150% and go home and not take this home with me, if that makes sense. So I do try to share that with the residents that their interactions with the patients are short, but so very important, and they will remember that.
So, what can radiology learn from specialties like OBGYN on how to incorporate some of these principles?
So we are, again, slightly lagging behind many of our specialty peers. OBGYN has done a lot in this area. There's a lot of literature out there from the ACOG Society, but as well as pediatrics and surgery and internal medicine has really done a lot in the area of trauma-informed care. So even just picking up an article and reading about what they are doing or asking your peers when they come into your reading room and asking you about a mammogram, having this conversation about how are you addressing this? For instance, our general surgeons who specialize in breast imaging introduced in our area of breast cancer the chaperoning and how important that was to have and include chaperones and normalize that space and that role for employees.
What has been the biggest barrier in your experience in implementing these changes?
I think as soon as you hear about some of the non-clinical skill that we want to introduce or we want to, increase, people immediately think, I don't have time. There's not enough time. But the reality is that trauma-informed care isn't about adding steps. It's about doing things differently, making many interventions take seconds, like pausing for consent during the procedure, explaining what you're about to do, asking if everything is okay during the procedure. They're not time consuming. These are just shifts in mindset.
So even though you say these things aren't time consuming, often if we want to start anything and we want to get buy-in to change, we need to start small. So what are some things, some policy changes, et cetera, that could create a quick impact that we could build on in the future?
Yeah, I think training is number one, and just creating policies around maybe knocking and announcing that you're going to be present or that you're going to be introducing yourself. Doing stepwise consent, which sometimes means consenting, like I said, throughout the procedure. It's not a checkbox. Also offering chaperones and documenting patient preferences so that your team is aware. One easy thing to do as well is just to get some outcome information from your patient by a single question of how safe or how comfortable did you feel today after your exam. And this is a question that can be on its own, or it could be added to a questionnaire that they're probably already filling out.
So, what does creating a safe environment or a safe space for these programs look like?
I think it means privacy, of course, in medicine, one of the major concerns and goals, but warmth, calmness, predictability is huge. Simple things like offering a warm blanket, playing soft music. I often will play spa-like music during the procedures, having calm voices, and letting them know the roles of everybody in the room and posting that as well for a patient to see who's going to be involved in their care.
How do you and your team, say, keep the procedures flowing while still pausing for consent?
So it's all about building consent into the rhythm of what you were already doing. So I will pause at major steps right before I numb a patient. Before I do the biopsy, there's a loud noise that our biopsy device use, and I will present that device noise to the patient prior to taking the biopsy, asking permission as you go and just checking in. And this does not take a lot of time because at the end of the day, if you do miss a step and there is a sense of re-traumatization, that can take longer, and the procedure actually will take longer if you miss that step and you need to actually take 3 steps backwards to restart a process in a normal procedure.
And for clarity, when you're talking about consent, you've already gotten the official consent to do the procedure, and now you're talking about consent like, is it okay if I put the ultrasound probe down? The next thing I'm going to do is inject the lidocaine. So you're kind of just, by consent, you're talking about how you're guiding the patient through the procedure and letting them know each step, correct?
Yeah, correct. Exactly.
I think we forget that. We explain the procedure to the patient, but they're scared. And then we think that they're going to remember everything we told them. And then they sit there. And I always tell them, I'm going to tell you everything I'm doing as I do it. There will be no surprises. And I think that makes them feel better.
That's exactly a great way to approach it too, because we do sometimes assume that we go through the consent in excruciatingly painful detail, and then we think, okay, all done. But we're not. We need to just kind of check in constantly throughout a procedure to make sure that they're comfortable with everything that you're doing.
I know when I was doing procedures, Dr. Weaver, who was my attending, full circle podcast today, taught me that. And so that's why I did.
Yeah. Because they forget, we're all scared when we're having a procedure, and, you can tell someone the 30 steps you're going to do, but they've forgotten by step 3 because they're scared, reasonably so. I just think that anticipation is the worst. So I will tell you what's going to happen. No surprises. So
It's okay to ask the patient ahead of time. Do you want to know in every single step and every detail? And most of them will say yes. This is anecdotally. But every now and then I don't want to know. Just get on with it.
get it done.
Just get her done.
Yeah. Can you think of any other small choices that can actually make a really big difference to our patients?
Yeah, there's something very specific to radiology that I think we do and we don't realize is that when we are actively scanning fluoro, doing something where we're present in the room and the imaging is coming up live, that we say, oh, that looks great. That's perfect. That's beautiful, which is now allowing and giving a power differential where we should just say, okay, that's normal. That looks normal. So trying to, again, change the language around that.
So when you're doing a procedure, what cues do you recognize in patients that tell you that maybe it's time to take a little bit of a pause?
Sure, there's a lot of cues. I also teach residents and med students. I say that over 20 years, 25 years of practicing, that anxiety and fear have over 1,000 phenotypes. And to recognize that there are so many different cues that can occur that really underneath everything represent fear and represent anxiety. So things that come to mind when you ask that question is a teardrop from a patient that has been pretty stoic the whole time during the procedure, and to take a moment and to offer them a Kleenex and say, are you okay? To see them clenching or reaching out for the technologist's hand to grab on because that maybe they're having extra pain that you just don't want them to have. So those are just some examples.
So now, as groups, organizations, and everyone start building these programs and approaches, feedback or feed forward is very important. So how do you suggest that they gather that information without burdening the patient with a bunch of questions?
Yeah, exactly. And I'm referring back to what I had said before too, is that it's a hard one because they are definitely overburdened with post-procedure surveys, post-experience surveys, and it could be as simple as just adding the question to it. If you don't have a survey, then just asking the one question of what helped you feel comfortable today, and leave it open-ended so that you can actually appreciate the comments that are provided. But my suggestion as well is to start small, to start in one division of a department and then look at that, assess the data, and then maybe expand it further out.
So, what do you think should be included in a good post-procedure summary, like when you're discussing what happened and everything with the patient?
So during today in modern times, is that the patients are getting information before we are. So after a procedure, it's very important to have a follow-up discussion of possible outcomes. And I think being very clear or as clear as possible with when will they receive their results. I can go ahead and give you my anecdotal experience with breast imaging after a breast biopsy. I will let a patient know that they will receive their results in 2 to 3 working days and that they may get the results before I see them. And what are the possible results? And we go through each possible result that I have on my differential that I think is going to present itself to the patient on the EHR. And then with every result possibility, I give them outcome next steps. For instance, the patient finds out that they do have a carcinoma, that the next steps, the conversation we have is that if the unfortunate results come back that this is a cancer, that we will provide and make appointments and ensure that you are taken care of to the best of our ability. So they don't feel like they're just hanging when they get a result and they don't know what's next. So I spend that time. And something that we don't often think about in radiology is it's okay to do a teach back method of asking the patient just so that I know I explained everything well enough for you to understand. Do you mind just summarizing what I explained to you? Or can you just give me an idea of what you would tell your partner or your parents when you go home?
Can you tell me how you see radiology making trauma-informed care a standard practice?
I think it's going to come from 3 places. Education, just like what we're trying to do with this article, culture, and policy. Policies will set expectations. The training can give staff the skills, and culture changes when leadership models this behavior. Then the team can see this and also start holding each other accountable. I think that the goal here is that trauma-informed care just becomes how we do things here.
So after you do all of these changes and you really want to start saying we are doing trauma-informed care, if you could pick just one outcome to measure, what would that be?
I would love to measure patient-reported emotional safety just right after their exam. When a patient feels safe, everything else follows. Trust, cooperation, satisfaction, and especially something we don't always think about in radiology too is adherence to follow-up care and the importance of that.
Well, thank you so much for sharing your insights today. This has been such a thoughtful conversation on how we can work together to provide better care to our patients.
Yes, truly, thank you so much for joining us, Dr. Klein. I encourage everyone to go read the full radiographics article and to check out the many other great articles the journal has to offer. Finally, if you enjoyed this podcast, please rate, review, and subscribe to it. By doing so, you help others discover the Radiographics podcast and help us expand our audience. Until next time, remember, behind every image, there's a person whose story truly matters.